Welcome to the Explainer. Today, we're going to put on our medical detective hats. We're going to decipher a routine, everyday lab result that actually holds the key to a massive global health puzzle. We're investigating microcytosis and iron deficiency anemia, pulling from the absolute latest clinical practice updates from the American Gastroenterological Association, along with diagnostic frameworks from the American Academy of Family Physicians. So let's dive right into this.
Here's our clinical roadmap for today. First, the microcytosis mystery. Second, diagnosing iron deficiency. Third, oral iron as our first-line fix. Fourth, intravenous iron interventions. Fifth, we'll look at complex gastrointestinal culprits. And finally, Section 6, the bottom line.
Section 1. The microcytosis mystery. A tiny clue.
Imagine you've just gone in for your annual physical. You feel totally fine, completely asymptomatic. But your doctor runs a routine complete blood count, a CBC, and hands you a printout with a flagged result. Your red blood cells are simply too small. So what exactly is this tiny clue trying to tell us?
Well, this condition is called microcytosis. Clinically speaking, it's defined as having a mean corpuscular volume, or MCV, of less than 80 in adults. Now, most of the time, this is a purely incidental finding. You obviously didn't come into the clinic complaining about small red blood cells. But for a medical detective, these abnormally small cells are the prime suspect, pointing directly toward an underlying anemia.
Section 2. Diagnosing iron deficiency. Interrogating the labs.
So how exactly does the doctor narrow down the suspects when faced with microcytosis? You've got smaller red blood cells, but that's really just a symptom. What is the root cause?
We have a lineup of usual suspects. The list includes things like thalassemia trait, anemia of chronic disease, and in some rare cases, lead toxicity. But the absolute most common cause of microcytosis in the United States, and frankly, the most common nutritional deficiency worldwide, is iron deficiency anemia. To prove this is our culprit, we have to look really closely at how the body handles its iron.
And this brilliantly illustrates how we can easily understand blood tests. Just think of your body as an iron bank. Serum iron? That's the cash in your wallet. It fluctuates daily based on whatever you just ate. Ferritin is your savings account. It reflects your true, long-term iron stores. And total iron binding capacity, or TIBC, well, that's the size of the bank vault waiting to hold that iron.
The absolutely crucial point here is how this banking analogy helps us differentiate between our suspects. In iron deficiency anemia, your savings account, the ferritin, is completely depleted. We're talking less than 15 nanograms per milliliter. Because you're so poor in iron, your body actually builds a bigger vault to try and catch more, so your TIBC goes up. Compare that to anemia of chronic disease, where inflammation actually locks the iron away. Your savings account, the ferritin, is normal or even high. But the vault size, the TIBC, is low, because the body is intentionally hiding iron from a perceived infection or inflammation.
Looking at the exact laboratory test differentials, you'll notice in iron deficiency anemia, the ferritin is decreased, the TIBC is increased, and the transferrin saturation, which is the percentage of the vault actually filled with iron, is severely decreased. Another really great clue is the red blood cell distribution width. This measures the variation in red blood cell size. In iron deficiency, it's increased because the body is erratically pumping out cells of all different sizes trying to compensate, whereas in conditions like thalassemia, it stays relatively normal.
Section 3. Oral iron. First-line fix.
You might think that if you're low on iron, you should just take as much iron as humanly possible, right? Actually, no. The American Gastroenterological Association explicitly states, give oral iron once a day at most. Why? Well, because when you take oral iron, your liver releases a hormone called hepcidin, which spikes and stays elevated for up to 48 hours. And hepcidin literally blocks further iron absorption. So taking iron 3 times a day just gives you terrible stomach aches with zero added benefit. In fact, taking it every other day might actually be the most efficient strategy. Let's see how this builds into our treatment plan. Oral iron is incredibly accessible. The AGA recommends starting with simple ferrous sulfate because 30 pills run for mere pennies, usually between 30 cents and $4. There's honestly no substantial evidence that fancy, expensive oral iron formulations work any better than the basic cheap stuff. You can add a little vitamin C to help with absorption, but generally, keep it simple and inexpensive.
Section 4. Intravenous iron interventions. The heavy artillery. A lot of patients simply cannot tolerate oral iron. It causes severe nausea, abdominal pain, and constipation. Furthermore, some patients have bodies that just flat out refuse to absorb it through the gut. In anemic patients, hemoglobin should rise by about 1 gram per deciliter within 2 weeks of taking oral iron. If it doesn't, we pivot to IV iron. IV iron bypasses the dysfunctional gut entirely and provides rapid repletion of your iron stores, though it definitely comes with much higher logistical and financial hurdles.
There are several IV iron formulations available, and the goal is to use ones that can replace your entire iron deficit in just 1 or 2 infusions. Take ferromoxetol, for example. It's highly effective, but here's a really fascinating medical caveat. It's actually a superparamagnetic iron oxide. That means it acts as a magnetic resonance contrast agent. So if you get this infusion, you literally have to tell your radiologist, because it will mess with any MRI scans you get for up to 3 months. Crazy, right?
But here's the catch with IV iron. Remember how oral iron cost about 30 cents? A single 1,000 milligram dose of advanced IV iron formulas like ferric dirisomaltose can cost close to $4,000. This perfectly illustrates the financial stakes of treatment. It's an incredible, life-changing intervention for those who need it, but the leap in cost from oral to IV therapy is absolutely staggering. Section 5. Complex gastrointestinal culprits, the escape routes.
If a patient is an adult man or a non-menstruating woman with iron deficiency, the absolute first thing a doctor must do is hunt down occult gastrointestinal bleeding. Is there a hidden malignancy? You have to check. Beyond that, there are specific chronic conditions that dramatically alter how we treat iron deficiency. Patients with previous bariatric surgery, inflammatory bowel disease, celiac disease, or vascular issues in the stomach all have significantly compromised iron processing.
This treatment matrix acts as a cheat sheet for gastroenterologists. Take bariatric surgery, like a Roux-en-Y bypass. It physically bypasses the duodenum, which is where iron is primarily absorbed. So oral iron is practically useless here. They need IV iron. The exact same goes for active inflammatory bowel disease. The inflammation prevents absorption, so IV is the consensus first-line therapy. But look at celiac disease. Often, just switching to a strict gluten-free diet heals the villi enough that cheap oral iron works perfectly fine again. It's all about matching the route to the specific mechanical failure in the gut.
Section 6. The bottom line. This quote from the AGA acts as the golden rule of modern iron deficiency management. Start simple. Try the inexpensive oral iron. But if the patient is suffering from side effects, if their savings account, that ferritin level, isn't growing, or if their gut anatomy is fundamentally compromised, do not hesitate to escalate. Intravenous iron is safe, and it's the necessary tool to properly heal these patients.
We've covered a massive amount of clinical ground today, from the basic MCV flag on a routine blood test to the complexities of hepcidin hormones and bariatric anatomy. So I'll leave you with this. The next time you sit in a doctor's office and look at your routine CBC, will you know what your ferritin is telling you? Are your iron banks full, or is it time to do a little medical detective work of your own? Thanks for joining me on this explainer, and keep asking the right questions.